again, and good evening, everyone. My name is Chris Malloy, and I'm a certified financial planner and senior advisor at TMFD Financial. This is our first webinar after the summer holidays, so I'd like to welcome everyone back, and I hope you had some time to relax and enjoy and unwind a little bit. I'd like to start off by thanking you for attending our presentation, The Top 5 Reasons Dentists Need to Understand Zygoma Implants, by our very special guest, Dr. Lesley David. Dr. David is an oral and maxillofacial surgeon practicing in Toronto. Now, many of you may recognize or know Dr. David as a regular speaker at various dental events, as a writer through her numerous publications, or as a teacher through her affiliation with Global Dental Mentors. Dr. David is an expert in her field, which is why we're so pleased that she's able to share her knowledge and her wisdom with us tonight. We're also fortunate to have Dr. Murray Arlen join us as co-host. Dr. Arlen is a periodontist himself and has overlapped professionally with Dr. David over many years, especially in the field of continuing education in implant dentistry. So he'll be able to add valuable insight and commentary to Dr. David's presentation. Before we begin, I'd like to briefly introduce TMFD Financial and explain the valuable services we provide to clients. Our goal is to make the financial lives of our dentists simpler by combining a variety of services under one roof, from tax and accounting, investments, insurance, and other financial planning matters you may have. The result is simplicity, peace of mind, and confidence in your financial decisions. In addition, TMFD Dental Academy hosts webinars like this one tonight to enhance both your clinical education and knowledge of wealth management. At this point, I'd like to hand things over to my colleague, Aaron Carabello, who's managing the technology for us tonight, and to provide some housekeeping items. Aaron?
Thanks, Chris. Now, for those unfamiliar with Zoom webinars, if you have any questions for Dr. David, Dr. Arlen, or Chris, please utilize the Q&A button found at the bottom of the screen or the device that you're on, and we will address the questions as they come in or at the end. Alternatively, there is an option to raise your hand if you would like to be called upon. There is also a chat button which allows you to communicate with anybody attending this webinar. In regard to PACE CE credits, these will be sent out within the next 2 weeks. And back to you, Chris.
All right, perfect. Thanks, Aaron. That's great information. And I'd like to add that TMFD is very pleased to be able to offer PACE credits so that you can get the most out of your valuable time this evening. So at this point, I'd like to turn things over to Dr. Arlen to introduce our speaker.
Thanks, Chris. First, I want to give a shameless plug to Chris and TMFD. I've been a client for about 15 years, and they are truly fantastic bunch. I always give them a good review whenever I get the opportunity. So thanks again, Chris, for everything. So as Chris mentioned, I've known Lesley professionally for many years. She is an oral maxillofacial surgeon with a private practice in Toronto. She teaches at the University of Toronto. She's an examiner for the RCDS. She's a key opinion leader. She's a member of numerous organizations. I'm not going to take up a lot of time going through all the details of her CV. She's well known worldwide in the implant industry, and she is co-founder of Global Dental Mentorship, which is a very good teaching institute academy on its own right. Now, I told Lesley I had a little bit of a personal anecdote. She's smiling now because she doesn't know what it is. So I'll relay it to you. So I was at a Nobel BioCare conference in Las Vegas many, many years ago. And Lesley was, and this was attended by about 10,000 people. It was really international conference. Now it comes to you, Lesley, right? And she was performing live surgery. She was in Toronto. It was on this huge, we're in this huge arena where they have boxing matches and seat like 10,000 people. They had two huge screens, and it was Lesley, David, and this other oral surgeon from the States who is still one of Nobel's main spokespersons. And they were both doing live full arch implant placement And it wasn't a race, but you couldn't help but compare. So I remember saying, Lesley, she had this patient with a lot of bone. She says, we grow them big up here in Canada. So she represented us Canadians very well. And I got to tell you, she was done with her case. And the other guy was, I don't even think, halfway through. Like I say, it wasn't a race, but she was extremely impressive. So as I say, Lesley is world-class and world-renowned in the field of implant dentistry. And also what's important is she's a really nice person. So what else can I say? Hand it over to you, Dr. David.
Thank you, Murray, very much. That's a very fond memory. Little did I know that they were comparing the Canadian to the American, and there was this hidden race. So yeah, I remember that very well. It's really my pleasure and an honor to be speaking alongside with you, Murray, because you've been one of my mentors and great teachers for a long time. So very honored to accept this, and to TMFD, I really appreciate the opportunity to speak for you and a lot of the dentists. So the topic at hand is the top 5 reasons to understand Zygoma implants. And a lot of people think this is just in the realm of oral and maxillofacial surgery, but it's an implant. And the reality is we really need to know what's available for our patients. So with that in mind, we then have to think about what can we understand from this topic, even if you're a general dentist, if you're a different specialist and not necessarily a surgeon. So in general, what I'm going to try to convey to you is really what is the zygomatic implant? Where do we apply it? What are the indications? What are the patient experience? And what's the reality with regard to this treatment protocol? So the one of the reasons, or the first reason I would say that we need to understand Zygoma implants, is because we as dentists, regardless, or anyone helping our patients, need to be the one educating our patients. I think now more than anything, we're in an age where social media has just taken over our lives, and dentists, patients all go to social media. They post, videos, they post, there's chat rooms, and depending on how many likes or whatnot, we think, oh, maybe I'll try this. Well, patients go to the same social media and they're getting information that may or may not be accurate. So it's really important for us as dentists to really keep on top of what's out there and what's available for our patients so we can treat them in the best possible way. Now, with knowledge comes obviously an understanding and an ability for us to communicate to our patients in a way that offers case acceptance, right? So many times I have patients come to see me, and even just a regular implant, because of the way it was explained to the patients are horrified, right? And dentists themselves think, oh my God, Zygoma implants, right? So we kind of have to, or I'd like to really demystify the whole concept of the Zygoma implant so that patients really can understand it. And the way that they can understand it is really through you. So if we think about case acceptance in general, and this is not really, only pertaining to Zygoma implants, but we have to think about really how much do we believe in a proposed treatment, right? What we value, what we think is important. Invariably, the way we communicate and how we feel gets transferred to the patient. We have to understand it to value it, to understand its benefits, to know what the applications are. And then, of course, we have to be able to communicate it. And each one of these things really kind of spills and feeds onto itself. We have to understand it to communicate it. We have to believe in it to properly communicate it. So sometimes dentists will call me up and say, how did you talk my patient into this treatment? And sometimes I almost feel like, badly, because I never see myself as talking someone into treatment. I'm very matter of fact. And I think because I'm just so matter of fact, and I have these core values about replacing teeth, that it just automatically gets transferred onto the patient. And the other thing we sometimes think about is cost as being a barrier. And it's often rarely the barrier. And it's about what we value, right? So if patients really value something, they're typically going to spend money on it. Case in point, a lot of people drive, fancy cars or take expensive holidays. they don't really think twice about it because they value that. So hopefully I'm going to help you to understand this and what the applications are so that you can properly communicate it to patients. So let's look at the implant itself. Yes, it's long. It looks like it's maybe something that belongs on your barbecue set, but I assure you it is a dental implant. Not really intimidating. It's just a regular piece of titanium, just a little longer than you're used to. Typically, although they can be a little bit longer depending on the system, but they range from 30 to 52.5 millimeters. And with progress over time and how we've developed this technique and the indications, there is a portion of the implant that's non-threaded, again, depending on how we're placing this implant. The head of the implant is offset, and it's an external hexed implant. So it's not a conical connection. There's a lot of hype about conical connection and platform switching. This is an external hexed implant, which works beautifully. All right. So I love external hexed implants. I'm sure, I don't know, Murray, how you feel, but a lot of my old external implants do really, really well. So I'm very comfortable with this. So we have to understand a little bit about the anatomy. The best way to think about it is that the main anchorage for this implant is in the body of the zygoma. So that's the cheekbone. And it goes from the maxilla and it traverses through either the sinus or lateral to the sinus, and I'll explain that a little more, and anchors into the zygoma. And the zygoma, as you can see here, outlined in green, is bordered by the frontal bones, obviously the maxilla, sphenoid, and the temporal bones. So it's important for me as a surgeon to understand anatomy, because when I place this implant, I obviously want to place it in the appropriate place. So again, just a little bit of a review of anatomy. You can see where the infraorbital foramen is, the nasal fossa. The implant apex, we want to sort of emerge somewhere in that area of the red zone. And again, it depends on whether I'm placing maybe one implant or two implants. But knowledge of the regional anatomy really allows me to place this implant in a very safe fashion, even though, you know, for those of you who aren't working and doing maxillofacial surgery, it's a little bit, you know, scary and daunting and intimidating. But the reality is when we do surgery, we're very familiar with this area, especially when we do orthodontic surgery or trauma. So if we just relate this clinically, if you can see, there's the crest of the ridge. The zygomatic buttress is really a very good anatomic landmark that's used to place this implant. And if you actually follow the trajectory of the zygomatic buttress, it's challenging to end up in an area that's inappropriate. We'll talk about that in a few minutes. So again, you can see here, the implant goes from the crest of the maxilla, passes sometimes through the sinus, sometimes lateral, depending on the anatomy, and ends up in the body of the zygoma. Now, the excellent anchorage of this implant is because it passes into the body of the zygoma and out of the body of the zygoma. So the intent of this implant is to engage those two cortices. And if we have enough bone in the maxilla, it engages some bone entering the maxilla and the floor of the sinus. So in some cases, it's actually engaging 4 cortices. In other cases, it's just 2 cortices. So again, you can see here, there's a window that's made, and you can actually visualize the placement and the position of that implant. The yellow arrow is basically a retractor that's placed in the frontozygomatic notch. And again, that's a landmark. So you're going to enter in a certain place on the maxilla, and you aim for a certain place with that retractor in place. Again, depending on the anatomy, you see here, sometimes it's going to be in the maxilla. And I think we're going to have another picture here. You'll see in, let's say, type 4 or type 3, the implant is completely lateral to the maxilla and lateral to the sinus. So we don't have to remember 0 to 4. I don't expect you to remember that. This is just an approach that we surgeons use. But the reality is the position or the head of the implant is on the crest of the ridge. And we've changed the technique over time. Sometimes it was very palatal, but the technique has changed to get it as close to the ridge as possible. And the apex of the implant ends up in the body of the zygoma. So depending on the patient's underlying anatomy will determine whether the actual body of the implant itself ends up intrasinus, just through the maxillary wall, or actually lateral to the sinus. Okay, so it's all anatomically dependent. The position of the implant is dependent on the prosthetics and the crest of the ridge. That's the prosthetic platform. The apex is dependent on obviously anchoring it into the body of the zygoma. So what does this entail from sort of a patient perspective? Essentially, zygomatic surgery can be performed under IV sedation or general anesthesia in the office. When I first started doing these, I thought patients would have so much pain, be so uncomfortable, similar to almost like an osteotomy. But realistically, it's quite amazing. They really don't have a lot of pain. Some people do have a fair amount of swelling and bruising, so they could be swollen under the eye, they could be swollen under the cheeks, the temple, and obviously because we know the fascial planes communicate with one another, they can even swell from the face all the way down, right? We know that infections can track down. It's the same thing. It's because of the fascial planes. So some people swell more, some people swell less, but typically pain-wise, it's not such a big deal. Risks and complications, I'll show you a slide on in a few minutes. We'll get to that. But there are some risks and complications we need to understand. Prosthetics. Again, this is an external hexed implant. And typically what goes on that implant is a multi-unit abutment. And I would place the multi-unit abutments. They're either standard multi-unit abutments or 17-degree multi-unit abutments that can compensate, if we need to, for the position of the head of the implant that's in an appropriate restorative place. I would say most of the time these are used for fixed prostheses, but you can absolutely use these for removable prostheses, okay? And immediate loading is very, very common. The one thing that's really important to understand, unlike other standard implants, these implants need to have cross-arch stabilization. So you can't, or be stabilized by uniting them or splinting them to other implants. You cannot load them as individual units. So even if I wanted to place the implant, put a healing abutment on, and then we didn't want to immediately load, for example, what we'd have to do is then hollow out a denture and actually makes holes into the denture. So there's absolutely zero pressure on that implant, okay? They have to be splinted. Considerations from a prosthetic perspective, because the reality is any implant treatment, it's really a prosthetic treatment, right? This is just a means to provide a prosthesis. We talk about zygoma implants, but it's a prosthetic treatment. This is just a means to get there in sometimes a more efficient way and a better way. So the considerations are, we have to look at the smile zone, transition zone, smile line, lip support, restorative space, occlusion, jaw relationship. So the workup for these, because they're mostly used in full arch situations, is the same as if you were to do any full arch implant. So as you can see here, we can't really tell what's behind this titanium, right? The position of the implants are such that you really don't know if this is a standard implant or if this is a zygomatic implant. And that's the goal. That's what we want. So these implants were first used by Professor Brannemark in 1987 for basically oncologic resection. So cancer patients who had major maxillofacial hemimaxillectomies and defects. And it was a way to anchor implants and provide prostheses. In 1997, it was used in non-pathologic scenarios. So it has been around for a while. And this is basically taken over, in some cases, how we restore patients from a reconstructive perspective. So the classic use of the zygomatic implant, and what most of the literature is on, we still have some other literature in what we'll call the quad zygoma, and we'll get to that. But the classic use is basically 2 implants placed posterior zones where we don't have enough bone, and combining that with 2 to 4 anterior implants. So that's kind of the classic use of these implants. The expanded use is by using zygoma implants, both anteriorly and posteriorly. So the posterior zygoma implants sort of end up in anywhere from the second molar site to, depending on the anatomy, depending on the patient's mouth opening, maybe the mesial part of the sixth. The anterior implant usually ends up prosthetically in the lateral or canine area, okay? So we can use 2 on either side for a full arch prosthesis. Now, I did mention and refer to potential complications. So historically, the most common complication was sinusitis, and this was typically secondary to an oral enteral communication or secondary to misdiagnosis of a lack of patency of the osteomeatal complex. So we have to have proper drainage in the sinus because if you did get an infection there, it can't drain. Now with the techniques that we have and the way that we place the implant, this complication is always mindful to us, but we've designed ways over time and changed the way the implants are placed to really decrease this as a complication. I'm not going to say it's not a complication, it can never happen, but again, if we navigate the surgery in a certain way, we can really minimize that. And as you can see here, you can look at these radiographs and you can almost see this radiolucency around those implants. And that's showing that there's literally no bone and an opening, and that's what can cause the infection in the sinus. The other note here is paresthesia. So as you saw from the initial slides that I showed and reviewing the anatomy, you saw the infraorbital foramen. So paresthesia really is a result of essentially retraction in the area. So there's really no reason to have paresthesia postoperatively if we're cautious, if we know our anatomy, if we're carefully retracting in the area, and we identify the nerve, preserve, and protect that neurovascular bundle. Infection is like any other implant. You can get an infection in the area with good preoperative and postoperative antibiotics. That is fairly uncommon. Recession of tissue, mucositis, periimplantitis can happen. The key with these implants, like other implants, as we've learned over the years, but I think actually with zygomatic implants, we learned this sooner or earlier, because we don't have a lot of bone often at the prosthetic platform. We really need to have a ton of keratinized tissue, thick keratinized tissue, because if we don't, if we have mucosal tissue, we will see recession in that area. So we design the incisions in certain ways. We do pedicle connective tissue flaps to get thick tissue. So we really sort of think twice about the surgery as to how we go about it to have as much keratinized tissue as possible. I put down here entry into the orbit because that is documented. I'll share with you one of the surgeons in Europe who actually taught me how to do zygomatic implants, Chantal Malavez, and I'm always thankful to her because if it weren't for her, I wouldn't be doing what I'm doing. But I was watching her in her operating room and had the opportunity and privilege to really assist her and learn from her. And someone asked her, what happens if you kind of end up in the eye? And she literally turned to them and said, very matter-of-factly, then you're a terrible surgeon, to which we all laughed. But obviously looking at the anatomy, one would think, wow, the eye is so close. And it is relatively close. But again, as I explained initially, the manner in which we navigate this osteotomy, understanding the anatomy, using our landmarks really makes it very difficult for you to end up in the eye. And of course, it's really not a practice builder. So definitely something we want to avoid. All right. And then finally, prosthetic complications, as with any other prostheses. I won't go into that, but you could have fractured prostheses, broken screws, so on and so forth. But again, that all has to do with how the prosthetics are designed, the preoperative planning, positioning of the implants, so on and so forth. So we do have some questions throughout this to make sure that everyone is super engaged and awake and enjoying this lecture. So the first question is select the best single answer. Zygomatic implants are not associated with any complications. Zygomatic implants can be associated with complications. Sinusitis may be the most common complication. And then D, B, and C are correct. E, all of the above are correct. F, none of the above. This is a very tricky question. So I'll give you 15 seconds to answer this question. And looks like can be associated with complications. Some people are backtracking. You can phone a friend if you want. The answer to this question is B and C are correct. So it would be D. And it looks like most people have answered this. So, very simply, we can understand that, there is zero surgical procedure, that has no complications. And in this case, sinusitis typically has been historically and probably still is the most common complication. But again, it's not, even though it doesn't happen all the time, it's still, of the complications, probably the most common. All right, we will carry on. So the second reason you need to understand zygomatic implants is that rehabilitation with these implants is really less invasive than conventional grafting. All right. So when we have these sort of scenarios, we have to ask ourselves, do we graft? Don't we graft? That's really the question. I can tell you that I spent much of my early career, my residency, even though I know it looks like I only graduated, 5 or 6 years ago, much of my time rebuilding maxillas. That's what we did as oral and maxillofacial surgeons. And there are probably surgeons out there who are still doing this. All right. The reality is, even though bone grafting techniques have changed over time, so now I don't have to go into people's hips or knees. I can use, BMP or allografts. We can use, bioactive materials. So it's made it a little bit, for sure, less invasive. But the reality is, we have to think about, even though if we can rebuild jaws, we have to ask ourselves, at what biological cost, right? What happens? What does the patient sort of have to endure? There's obviously morbidity, there's time, there's excess cost. So we have to take that all under consideration. And there really has been a shift over time in what I would say the reconstructive mindset. And instead of us, thinking we're going to reconstruct these maxillas and even mandibles, by the way, now that reconstruction has more to do with a prosthetic reconstruction, right? So we're using pink acrylics, pink porcelain to really rebuild the jaws instead of rebuilding lost anatomy, okay? And we're doing that because we know we can get good outcomes and excellent outcomes without major interventions. So another question for you all. Bone augmentation techniques may be associated with increased cost, treatment time, morbidity, risks. All of the above or none of the above are correct. And it looks like, yeah, I know these are challenging questions here, but we didn't want to have too many people being stressed out on a Monday night. So everyone said all of the above. That is correct. Excellent. All right. Let's go to the next topic here. So the next thing to really consider is that Zygoma implants are typically immediately loaded. So it's very uncommon that I would not immediately load an implant. And as I alluded to earlier, because of the anatomy, we often have excellent anchorage. So these implants, when I place these implants, really bottom out at 35, 40 Newton centimeters. There's a special instrument we use to place them in by hand. And everything is planned on a computer, all right? So we can see exactly how much bone is around our implants. I can determine the position of the implants. And even though, as you can see in many of these cases, there's no bone at the level of the maxilla, we still have bone at the level of the body of the zygoma, and that will actually provide us with good anchorage for our implant. Now, this is a patient who was referred to see me for the biopsy of a tongue lesion. She did not come to see me for implants, but it's one of those things where when you do things, it's hard to ignore what you know, right? So the patient takes her, sort of partial upper denture off, and I look in her mouth, so on and so forth. And I cannot help but ask her, sort of what's going on with her mouth and how she enjoys her partial upper denture. I mean, can you imagine being whatever age, it doesn't really matter whatever age, and walking around looking like this, right? Why do people, if you think about it, I tend to like to understand people. So, I thought, here's someone who's 51 years old. Why is it that this woman, and she, was nicely dressed and took care of herself, walking around like this? And a lot of people walk around looking like this for a couple of reasons. One is fear, right? Fear of the dentist, fear of treatment. And two is sometimes unknowing, not being informed and being unaware of what's actually possible for them. So I started to chat with this woman, aside from the biopsy, again, so how's your denture? What do you think? Have you ever thought of, getting rid of the denture? To which the conversation just sort of meanders onto, oh, I'd love to get rid of this denture. I hate it. I'm 51 years old, but I was told that I have to get rid of my teeth. I have to wear a full denture for a while. And then, we discuss implants. So I felt, very sort of in a situation where I couldn't help but discuss a potential treatment option for her. So this is, again, a scenario whereby our sort of all of our knowledge, and especially those of you who are general dentists, have such an impact on people's lives, right? And it's just a matter of not necessarily being able to do a treatment, but just having the knowledge of the treatment of what's out there. So of course, you can probably understand where I'm going with this. This patient had a quad zygoma, and this was immediately loaded. So the patient did not have to have, a denture that she wore forever. And this completely changed her life, right? Completely changed her life. Now, what about zygoma implants with regard to literature support, and how predictable are they? So there is a ton of literature, and this is kind of beyond the scope of tonight's lecture, but there's a ton of literature supporting the single zygomatic implants combined with those implants in the anterior maxilla. And depending on the study, the survival rates are 94.2 to 100%. So yes, this is a survival rate, not a success rate, because first of all, zygoma implants are basically, are really hard to measure success rate in looking at exact levels of bone around the implants. Because as you can imagine, the way the implants are placed, determining exactly bone levels at different points in time is challenging, all right? Because of the way the implants are angled, because it has an offset head. But it is a very predictable procedure with high survival rates. Now, the other thing too, and these are just some other studies, these are studies with regard to immediate loading. And even the immediate loading studies have high survival rates. Again, 96, 97%. And these are older studies, so this is not new. There's studies dating back to the early 2000s as well. Now, with regard to looking at systematic reviews and looking at failures and different quad zygomas, because that's the other thing we have to think about is, what about looking at when we're using two zygomatic implants per side versus one zygomatic implant on either side plus conventional implants. So remember I said that the quad zygoma has less literature. We're getting more literature over time, but the literature that we have does support these same cumulative survival rates, all right? The studies that we have on this one is 4 years. We don't have 15-year studies on these, but we do have, there's a publication coming out on 10 years for the quad zygoma that's at 94%, all right? The oldest study that we have using zygomatic implants initially published in 2004 was the Brannemark study, and that was a 5 to 10 year follow-up, 94.2%. That was not immediate loading, but Carlos Aparicio's studies in 2012 with a 10-year follow-up with immediate loading was a high cumulative survival rate of 97.7%. So in summary, the reports do suggest that the quad zygoma format may actually be a better way to rehabilitate patients for the severely atrophic maxilla. And we'll talk about when we would use sort of 4 zygomatic implants versus 2 zygomatic implants. Again, these can be used in cases where we have absolutely no bone in the maxilla, and we can immediately load these scenarios. In one study that talked about and looked at sort of patient satisfaction, looking at comfort, aesthetics, function, speech, and they compared conventional prostheses with conventional implants to those rehabilitated with zygomatic implants, they really had no difference from a patient perspective. All right, so that's important to understand. We can do a lot of work to rehabilitate maxillas and a lot of surgery, but at the end of the day, what the patient experiences typically has been, from the studies, no different. All right, so we have another question here. So this question says, select the best answer again. Zygomatic implants may be used for immediate loading. Their survival is similar to conventional implants. Zygomatic implants have an unthreaded portion in soft tissue, and their lengths range from 30 to 52.5 millimeters. Let's see. So most people are answering all of the above. Some people are answering the length is correct. So those of you who answered just the length is correct. The reason that all of the above are correct is that they have, if we look at the answers, they definitely can be used for immediate loading. And that's the big plus, I would say, about using Zygoma implants, is that it allows us the ability to not have to graft and do major reconstructive efforts, which allows us to immediately load. Their survival is similar, and in fact, many of these implants do have an unthreaded portion that we use adjacent to the soft tissue. So that's a big benefit. All right. So let's just go back here and let's look at the final, sort of a final reason why we need to understand zygomatic implants. And this kind of really puts it all together for us. So zygomatic implants close the gap in the all-on-4 treatment option. So all-on-4 treatment is really a trademark by Nobel Biocare, but I like to sometimes say it's an all-on-X treatment because sometimes we need more, or we decide to place more than 4 implants. But a lot of people know this as the all-on-4 treatment concept. So let me just take a few minutes for those of you who aren't familiar with all-on-X or all-on-4 as a concept. And the best way to think about it is it truly is a concept. And the concept is one whereby the goal is to bypass grafting, okay? And we use tilted implants to bypass grafting, number one, and to allow us to immediately load a prosthesis, okay? So if we look at here, the maxilla and the mandible, and you look at where the sinus is, we're tilting an implant, and the prosthetic platform is ending up further distal than it would if we were to place a conventional implant. So if we placed a conventional implant here, you would see that I can't go so far back because the sinus is there. So because I want to allow myself the ability to restore this patient further back, but I don't want to graft and do a sinus lift. You could do a sinus lift, but that means more surgery for the patient. You can't immediately load this patient. So I'm going to tilt the implant to allow me to have a greater spread of the implants, but also to allow me to restore this patient further back without grafting. So that's the use of the tilted implant, and the same applies in the mandible. So if you look in the mandible, for example, where the mental foramen are, I have a couple of options. If I wanted to place implants really far back or posterior to the mental foramen, I would have to graft, or I could tilt the implants and end up with the prosthetic platform further distally than I would if I used conventional implants. So this concept allows us to decrease the cantilever because we can restore it further distal without doing grafting. High potential for immediate loading, and less cost because we're using less implants. So again, this is just that all-on-4 concept in the maxilla and the mandible. If I placed a straight implant, I couldn't go so far back. Now, the number of implants over the years, interestingly, if we think about where we started with Professor Brannemark many, many years ago, the initial implants were to rehabilitate full maxillas and full mandibles. And his initial studies actually were with 4 to 6 implants. And we are where we are today because they actually worked. But somewhere along the line over time, we felt the need to place many more implants. So sometimes 10 implants are placed, 12 implants are placed. But if we look at the literature, and this is actually from 2014, and we look at the optimal number of implants for fixed reconstruction, this is a review of the literature, and it was looked at articles over 30 years. The conclusion is that since the 1990s, it was proven that there is no need to install as many implants as possible in the available jawbone. The overwhelming majority of articles dealing with standard surgical procedures to rehabilitate edentulous jaws uses 4 to 6 implants. Now, that's not to say there are times where we may want to put more implants, but we do know that we can restore full arches with 4 to 6 implants predictably. So how do we decide, do we just use conventional tilted implants? Do we use Zygoma implants? How do we decide when we look at the maxilla? Again, this is sort of a prosthetic treatment, but we also have to look at how can we accommodate the prosthetics with our implants? So what can we do from an implant perspective to accommodate prosthetics, but also potentially minimize surgery for patients, allow for immediate loading, and so on. So if we look at, this is a classic article by Ed Bedrosian from the States, and he divided the maxilla into four zones. The anterior maxilla is zone 1, premolar area zone 2, and zone 3 is where the molars are, and zone 4 is the zygomas. And essentially what we do is we look at a CT scan and determine where do we have bone and where can we place implants. Do we need to tilt implants? Do we need to place Zygoma implants? So if we look at this, so if we were to say we have bone in all of these zones, right? I'm not really going to tilt my implants. I can place conventional implants. There's no reason for me to tilt implants. There's no reason for me to place Zygoma implants, okay? I'm going to use the standard protocols that we used once upon a time. Now let's say we have implants, we have bone in the anterior maxilla and the premolar area. So if we have bone in the anterior maxilla and the premolar area, I can tilt implants and make use of the bone there, and I don't have to do sinus lifts, right? And I can place implants and provide this patient with an immediate solution. Now let's say we have either no bone in the premolar area or the anterior extent of the sinus is fairly anterior, so it doesn't go so far back. So it limits how far distally, even if I tilted an implant, how far distally I can get that distal implant. Or the slope of the sinus is not so, is more acute rather than actually slope. That's also going to limit how far distally I can place the prosthetic platform, right? So the extent of the sinus, the slope of the sinus, or if I have no bone in that premolar area, the options are, of course, you can graft, and of course, you can do sinus lifts. But if we're thinking about a procedure for the patient that's a little bit more immediate, then we would think in terms of placing a zygomatic implant. So that's where the zygomatic implant comes into being. So let's answer this question. What's the best answer here? Zygomatic implants are used with severe maxillary bone loss. they can avoid the need for grafting, and they can avoid the need for sinus lifts. All right. You guys are awesome. This is good. Everyone's answering, can avoid the need for bone grafts. Yeah, pretty much everyone's answered. Sinus lifts can avoid the need, all of the above. So all of the above would be correct. Some people answered can avoid the need for bone grafting. I guess that question sort of speaks for itself. When we do a sinus lift, typically we're going to bone graft as well. And they're used with severe maxillary atrophy. That's why all of the above would be correct, because typically they are used with severe maxillary atrophy. If we have enough bone, we're not usually going to use those. Unless we have bone of poor quality, then we can't get good stability, then we would use a zygomatic implant, because we know we can typically get excellent stability with those. All right, so let's say we only have bone in the anterior maxilla. So then we're going to, again, place the implants in zone 1 and use zygomatic implants posteriorly. Of course, we could have done sinus lifts, but again, this is an immediately loaded case. This is obviously the final prostheses, but we wanted something that was more efficient without bone grafting for this patient. So now what about this scenario? This scenario is one whereby we have no bone anywhere. All right. So I don't have bone in the maxilla anteriorly. I don't have bone in the premolar area. So we then have to think of, what are we going to do in terms of rehabilitating this patient? And as you can see here, this is what we call a quad zygoma. Okay, so this is when we have no bone. The alternative to this would be to sinus lift, onlay grafting, so on and so forth. But if we're going to do that, we have to kind of think of, how do we temporize these patients, right? What are we going to do? If we're going to do major onlay grafting, how are these patients going to wear their prostheses? So it becomes much more complex, much more of a complex treatment. So you can see here, this is a classic sort of quad zygoma. And you can see that in this case, part of the head of the implant is covered by bone, and part of the implant is perforating sort of through the maxilla. And posteriorly, you can't really see any of the zygomatic implant, because it's going actually through the sinus. Okay. In this case, you can see the implants completely lateral, right? Now, I say completely lateral, but it's a bit deceiving. They are somewhat embedded in the bone. So they're not, really sticking out totally. They are somewhat embedded in the bone. But as you can see here, they're not really going, they're partly going through the sinus, but really quite lateral. And the reason being is that we want the head of the implant to be in a certain place, the apex of the implant to be in another place, and then the trajectory just depends on the actual patient's anatomy. And this is not, you don't graft over top of this, right? We then close the soft tissue, and now you can understand why the soft tissue and the thickness of the soft tissue is so important, right? We need to have really good thick tissue in that area. Otherwise, you can imagine if this is open and you have mucosal tissue, you can get an infection spreading, all the way up the length of the implant. And this is what really struck me many, many years ago, to think, tissue, people say, bone sets the tone, tissue is the issue. The tissue is just so important around our implants. And this is the exact reason why it's been in my mind for a long time, that we really need to focus on the tissue. All right. So another question here, lots of questions, but they're fun. Conventional implant placement may not be possible due to, all right, inadequate bone quantity, inadequate bone quality. All of the above are correct. Excellent. You all got this right, I believe. Nobody had to phone a friend. Good stuff. This is good. I love it. Okay. So now I show you this really just to show you that we really have the ability to treat all sorts of patients, right? And it's really just about kind of understanding the application of what we're doing and then deciding where and when to do it, right? So patients come into the office and we need to diagnose and understand where we apply what. I've only talked about fixed prostheses, but of course, this can be done for removable, right? This was a gentleman who came to see me. He was from Quebec. And, we have these, preconceived notions of what's ideal, right? For me, I can't even imagine having something removable in my mouth. And this gentleman came to see me, and he was in his mid 50s at the time. And he had been a dentulous since he was a late teenager. Imagine that. In Quebec, the dentistry, oftentimes in these small towns, they didn't fix teeth, they would just extract teeth. So can you imagine having a denture for that long? So I thought, I'm going to be this guy's savior, right? I'm going to give him this fixed prosthesis. He's going to love me. He's going to be so happy. And sure enough, when I talked to him about it, he thought it was the craziest thing to actually have something that's screwed in. He felt that this denture was literally a part of him. And his chief complaint was just like, it was sliding all over the place because he really had no maxilla to have it firmly anchored. So he just wanted something to ensure that he could speak and talk and feel self-confident. But the notion of getting rid of this denture that he could take out and he could clean for him really didn't make sense. And I thought, okay, that's no problem. We can do that. So this was immediately loaded, and this was done many years ago. This rudimentary bar, I don't even know the proper technical term. That's my surgical term for it. It's a rudimentary bar. You can see on the left-hand side of your screen. That was fabricated literally within about 1 to 2 weeks. And he had a denture that was then hollowed out and soft relined. And then eventually he had this more sophisticated bar to use. So I bring this to show you that, again, sometimes we have these notions of what's great for patients, but we really need to listen to understand what the patients want. And this treatment option can be done with removable as well. So individualized patient care is really important. Less invasive solutions for patients. Professor Brannemark, for those of you who don't know who he was, he actually was the father of osseointegration, who really found out and identified that in a little rat study, the titanium could anchor to bone. And so he's often quoted in the literature, and he's, often talks about what's best for patients and individualized patient care. And in this sort of quote, he says, a decisive factor in patient care is simplification of dental treatment, which should be based on identifying and utilizing the enormous capacity of existing original anchoring tissues. When possible, one should avoid unnecessary, advanced, and complicated major grafting procedures. So, I started sort of this lecture with the woman in shock of, oh my goodness, a zygomatic implant, right? And many of you probably prior to this talk, and hopefully maybe not still, think that this is a crazy surgery. But the reality is we have to really think about, what treatment options we had prior, what we can do now, and understanding that as things evolve, sometimes we can actually make things a little bit simpler for patients, even though the procedure itself is obviously more involved than placing a regular implant. But if you look at the big picture, it is a simplified treatment solution. And, I focused on, in many cases, the completely edentulous patient, but, we have to think about those patients who have failing dentition. This is also a very important concept for them. And in those patients, what's really important for them oftentimes is the concept of immediate loading, right? Patients who have had dentures for a long time, they're not so fussed. They don't need to have an immediate treatment or an immediate solution right away because they've been wearing something removable for a long time. But those people who have failing dentition, they're often very attached and emotionally attached to their teeth. So I think this is something that's really important that we at least have in the back of our minds as something to consider. So when we think about it, completely edentulous patients, terminal dentition, partially edentulous patients, we can use these for immediate loading. It offers shortened treatment timelines, fixed or removable solutions, and it's really a less invasive treatment solution. Now, I'd like to close by sharing with you a patient of mine who I met many years ago. And, you know, we probably all have those patients who just stick with us, right? Like people who kind of not just change your professional lives, but even almost change your personal lives. Like, I think that's what's so amazing about what we do as dentists. You know, I love being a dentist because I get to really enjoy and understand people's perspectives, their lives, especially older people. I always ask them, you know, like, what's your secret? You know, some of the 90-year-olds that we see are just filled with vitality and positivity and youthfulness. So this woman came to see me at the time. She was 83. And she basically said, I finally want to get rid of this denture. She's an ASA2. She has obviously complete maxillary edentulism. She had inadequate bone in basically the zones 2 and zone 3. So the premolar and molar sites. And she really didn't want any major surgery. I'm going to give you a little bit of a history on this patient. She is taking care of her daughter, who's at the time was in her 50s. She had a genetic congenital disease, and she wasn't supposed to live beyond her teenage years. And this woman spends every day going to visit her daughter, doing things for her daughter, as if, you know, she's a 40-year-old or a 30-year-old or a 25-year-old. She's also a master swimmer. So she's won multiple swimming awards. She even got an award from President Bush, winning a swimming award. And so she really just, you know, struck me. And, you know, on the one hand, I thought, wow, she's 83 years old. And sometimes we think, you know, does someone at that age want to do this? And again, these preconceived notions of age and what should be done or shouldn't be done. And we really need to sort of get rid of our internal biases and let sort of what patients bring to us dictate what should be done. So you can obviously imagine here why I'm presenting this patient to you. So she's at this point, she's 84. This is a 1-year follow-up. And you can imagine here that her Murray's probably shuddering by looking at this oral hygiene in this picture. I can understand Murray, and look at the perio-involved tooth. I can understand that too. And, you know, we look back at these and say, you know, what are we thinking? But the goal in my mind was really to address this patient's concern. And, you know, she is wearing this plastic prosthesis. So she came back. She's definitely not going to win any awards for her oral hygiene. But she came back to see me. Actually, I'm going to play this in 1 second. I'll show you the follow-up many years later, but I'm going to show you a video of her at she's sort of 84 years old, is a 1-year follow-up. And now I'm going to show you, I think she's 92.
I'm the wrong person.
So I asked her, what's your secret?
Sleep enough. I have too much pressure.
So I asked her, what's your secret to a long, healthy life?
I'm the wrong person to ask. I don't sleep enough. I have too much pressure. I have lots of stress.
Yeah.
But I have breakfast.
Yeah.
Regardless what time I get up, if it's 4 or 5, I eat nutritiously. I don't eat any garbage. I don't drink maybe half a glass once a year.
Wow.
I drink lots of water. I am a master swimmer. I swim 3 times a week. Well, we get 45 minutes, you know. I am the coach for the severely disabled, which I wasn't able to do because they haven't did the pool since the pandemic. But I take my little one to Oakville, Trafalgar, which built a state-of-the-art pool, 92 degrees, which you press the button and it gives you a massage. And I give Ellie I give Ellie her physio in the water once a week, every Saturday.
So pretty remarkable, right? Like this is a woman who's taking her daughter swimming. She's 92 years old. Then I asked her, what at this point in her life, right, in her 80s, made her want to actually get rid of her denture. So this is the next question that I asked.
It's swan freestyle. I flipped over, and the next minute I look up under the water, and there were my dentures floating because they weren't adjusted. But I have them in now. I rinse them with salt water every night, regardless where I am, whatever country.
So this is I just think this woman's so adorable, right? She's swimming and her dentures are floating up, and she's still rinsing with salt water every night. It's like so cute. So, here she is, 92 years old, 9-year follow-up. And definitely for those of you who are, aesthetic dentists, you're shuddering. I know this is not aesthetic dentistry. The aesthetic police are going to come and take me away. But the reality is I do believe that this is successful dentistry, right? This is something that has really changed this woman's life, who after many, many years of taking care of her daughter has essentially decided to do something for herself. And as you can see here, you can see there's a wire that is actually between those two front implants. She's still in the same prostheses because she's 92 and has no time or focus to get it changed to a final prosthetic. All right. So I bring this up really not because this is about me, but this is actually about you and each and every one of you who is sitting there tonight. If we think about it, people come to see us. These random strangers walk off the street and walk into our office, right? And they walk into our office with this inherent trust. Why? Because we have this DR in front of our name. And it's really up to us to educate ourselves so that we can provide patients with opinions, ideas, solutions. If you think about it, it's an amazing, amazing responsibility that we have to patients who come in and trust us implicitly. There's a bit of a power to that, right? And we have to take that power and use it responsibly, with integrity, and with compassion. People often talk about the edentulous predicament because it's been so challenging to deal with patients who have completely missing teeth or the failing dentition. But hopefully tonight, I've really sort of piqued your curiosity, demystified the Zygoma implant, and provided you with the notion that edentulism really presents to us many opportunities that really allow us, not just me, but all of you, to single-handedly help and change people's lives for the better. Thank you very, very much. It's been an utter pleasure for me to be with all of you tonight. As Murray mentioned, I'm part of a online platform of CE continuing education called Global Dental Mentorship. Murray's actually one of our mentors, and he has on there a fantastic implant lecture that I encourage you all to go on and listen to, because it's really going to enlighten you and help you to do better at implant dentistry yourselves. It's a fantastic series of lectures. This is the QR code for those of you who are interested in just signing up to our platform and getting different newsletters and information. So I leave you with this quote: excellence is not a matter of chance, it's a matter of choice. And through education, all of us, we can do better and the best for our patients. Thank you very much.
Can you hear my audio?
I can.
Okay, great. So don't go away, anybody, because we have some questions to ask. But before we do that, first of all, I want to thank Dr. David for an excellent lecture. As you said, first, everyone needs to educate themselves, because zygomatic implants are not something that's familiar to probably anybody here today other than you. We have a responsibility to educate our patients, and and also to refer them to you, Dr. David. I'll include that part too. Also, before we pose the questions, once again, I want to thank TMFD for sponsoring this whole TMFD Dental Academy, which is, we've had excellent lectures, and of course, Dr. Lesley, David as well. So we have some questions. 2 questions from the attendees concerning the same idea, a concern about potential danger to of anatomical structures that are in close proximity. The sinus you mentioned, yet conventionally, some dentists fear that, oh, you can't possibly perforate into the sinus. That's doomsday. Obviously, you're doing that with many of your implants, and someone also mentions the sphenopalatine artery, or for that matter, any other vital structures. You talked about the orbit, but any other vital structures that are potentially a risk.
Yeah, so let me address the sinus first. I know, classically, the thinking is if you're going to place a conventional implant in the posterior maxilla, you can't breach into the sinus. This definitely does show you that you can. And I'm not saying you intentionally, if you have 10 millimeters of bone to the sinus and you're placing a conventional implant, that you're going to place, a 13 millimeter implant. There's merit sometimes if you have soft bone to engage the floor of the sinus, the cortical bone of the floor of the sinus. So you might go to the floor of the sinus, and if you perforate a little bit, it doesn't concern me. There have been, so Professor Brannemark in his earlier days did some studies actually on these zygomatic implants with an ENT surgeon, where they did a nasal antrostomy. So post zygomatic implants, they actually went back to look at what's the effect of having an implant pass through the sinus. And so through antrostomy, they found that either the Schneiderian membrane completely bypassed the implant, or it covered the implant, but there was no sign of inflammatory changes of the Schneiderian membrane. So the biggest, and I kind of alluded to this, the biggest impediment to having issues is if the meatus is, so the drainage of the sinus, the osteomeatal complex, which is where the sinus drains, if that is not patent. So one of the important things to sort of understand before we do this surgery is what's the status of the sinus? So is the sinus clear? Is it opacified? Is there appropriate drainage? So even in patients who, let's say, did have a sinusitis, if they have a blocked complex, osteomeatal complex, and they have what's called an antrostomy, or a functional sinus endoscopic surgery, whereby ENT surgeon goes in and actually opens that complex, the sinus will drain and the implant does not have to be removed. Okay, so that's important to understand. Now, if you have an oral antral communication, that's a different story. Then you're getting bacteria going into the sinus, and that sets it up for any other oral antral communication. Let's say you extract a tooth and you have an oral antral communication, you're going to have the same potential sort of fallback, if you will, if you had an oral antral communication from any other reason. So hopefully I addressed that. The next question was anatomy. So the other potential anatomy is, so there's the orbit. The only other sort of real anatomy to be aware of, obviously there's the infraorbital foramen, but when you're placing this implant, you can perforate into the infratemporal fossa, right? So if you're not mindful of the sort of medial lateral positioning of your implant, then you can perforate posteriorly, and then yes, there are structures there that anatomically can be damaged. But again, as I mentioned, we use the zygomatic buttress as a landmark. And if you hug the zygomatic buttress and we understand sort of depth perception of the body of the zygoma, there's really no reason to enter out of that sort of sphere, so to speak. But it is a technique, and Murray, we talked about this earlier, that does definitely take some understanding of the anatomy, because you are working, you're not just working in the level of the level of the maxilla, you're engaging the maxilla and you're engaging another portion of anatomy at the same time, right? So it's getting that trajectory exactly where you want it in two places that takes sort of a real understanding of the landmarks.
Thank you. Now, you mentioned about your cases are, you do a cone beam CT, you plan the placement of the implants. You didn't specify. I'm presuming you're doing these freehand. Yet we know that for conventional implant placement, there's a lot of growth in either static guides that are computer planned or even dynamic navigation. Do you foresee that in the future, this may become a more common method for maybe surgeons who have less experience or confidence than you have?
For sure. So, I mean, right now, people are doing this with navigation. You can't really do it fully guided, but you can do it partially guided. So people are using guides to direct the initial path of the osteotomy. So, navigation is definitely a field that I think is going to open up for sure in this realm. There are not a lot of people doing it with navigation. It is something that I am currently working on, but traditionally and most of the time I am doing this, freehand.
Now, you mentioned that you do this both under GA and IV sedation. So ballpark, how long is a surgical procedure, and what percentage of your patients opt for GA versus IV sedation?
So I would say when I first started out, and it's funny how you change as you practice, I was doing this only under IV sedation. So it's just, that's how I was taught and so on and so forth. Now I do have some anesthetists, medical anesthetists who come to my office who do some procedures under general anesthetic. So for me now, it's almost a no-brainer to do this. Unless I had a patient who said, for whatever reason, I don't want to have a general anesthetic, it's fine. We'll do it with sedation. But for me, the fact that I can have an intubated patient totally asleep, I don't have to think about doing the anesthetic, is really easy. So I would say most of the time now, I really do this under general anesthesia. What was the second question?
Approximately how long is the procedure?
Yeah, so the surgical procedure for me to place two, let's say a quad zygoma, that would take me a couple of hours for sure.
Okay. Couple of questions asking about ballpark costs for either a quad zygoma or two zygomas and two or more anterior implants, so these potentially referring dentists can give their patients a ballpark figure.
Sure. So most of the time when I place these implants, I'm also placing the multi-unit abutments, and I'm also typically providing a transitional prosthesis. So we didn't really talk about that, but these transitional prostheses can either be made by converting a denture chair side, or nowadays, what we're often doing is scanning the arches and 3D printing these, so the chair side time is a lot less, and they can just be screwed in. But for me to see a patient, extract teeth, place fours, I'll give you an example of quad zygoma, because I do a lot of quad zygomas, and provide the patient with a fixed temporary prosthesis, you're looking at around $20,000.
Okay, good. Question about what would be your contraindications for placing zygomatic implants?
So active disease in the sinus, any pathology in the body of the zygoma, to do a quad zygoma, if you have very little bone, to put two implants in the body of the zygoma. And then I would say any other, typical contraindications. If I had a patient who had radiation to the zygomas, I wouldn't do it. Any other, if a patient can have regular implants, they can have zygomatic implants. The other contraindication I would say is patients who have, for whatever reason, scleroderma, some sort of TMJ internal derangement where they have limited mouth opening. So they have to have reasonably normal mouth opening, because the armamentarium and the manner in which we place these implants is at quite an angle that I need to sort of get in there to place the long implants. The drill bits are long, so on and so forth.
Now, the studies quote 94 to 97% cumulative survival rate, which means that 3 to 6% fail. How difficult is it to remove a 52 millimeter long implant?
So, so I'll tell you. So when I first started doing them, I haven't seen really many implants that didn't integrate. So it's been a while since I've seen one that doesn't integrate. So if it doesn't integrate, you can imagine that's easy. It just comes out. What I have seen, 3 over the course of, I started doing these, I guess, mid 2000. So I have seen 3 fractures. So those have been more challenging in the sense that in one of the cases, it was a quad zygoma. And I really was sort of in a conundrum of how am I going to get this implant out? You can imagine, to get it out, if it's integrated, you'd have to do an osteotomy at the body of the zygoma. So of the times that I've seen them fracture, I've actually left it in and just put, so I've, cut it and decided, everything you do in surgery is always about risk versus benefit, right? Risk versus benefit, morbidity. So in the one case where I had done a quad zygoma, I would say that was the most challenging case, because I really had to navigate placing a 3rd zygomatic implant. And how can I do this? So, you talk about using navigation, using guides. This is one case where I thought, okay, I really actually 3D printed the body of the zygoma and did the surgery freehand to be sure that I could take what I'm doing on the model and translate it. And this was years ago, but in my mind, I thought, there's another way that I can make my life easier. But needless to say, it worked fine, but it was challenging. So to remove it, I'd say I'd have to have a good reason to go into the body of the zygoma to remove it. I've never had to do that, but you'd have to trephine it out, remove some bone. So again, I'd have to weigh risk versus benefit.
And related to fracture risk, do different manufacturers use different grades of titanium, different strengths? I would think with such a long implant, there's a lot more bending involved, so fracture risk would be more of an issue.
Yeah, 100%. Some of them are narrower than others, right? If they're not properly loaded, if the forces aren't distributed, if you have a patient who has, is dentate in the mandible versus a patient who has a complete lower denture. So the prosthetics, and that's why I say the prosthetics to this are really, really crucial. If let's say the prosthesis becomes loose, and then now if the prosthesis is loose, now they're independently loaded. They're not splinted. So there's a greater chance of fracture. So, I'm very, whether it's a single tooth implant or it's a full arch implant, I always tell patients, if any prosthesis comes loose, it's not something we want to sit on, right? Because things break, screws break, implants can break, so on and so forth. So yes, there are differences with different manufacturers.
A question from an attendee: how do you decide on the length of the Zygoma implant to use, since humans differ in, I guess, the size of their zygomatic bones? So I presume you do that on your CT scan, but...
That's a very good question. So you can ballpark it on the CT scan, but we actually have a special measuring tool that allows me to, so once I drill the osteotomy, I then place this little measuring tool up the osteotomy, and it literally hooks external. Remember I told you that when you drill the osteotomy, you perforate through the external cortex or the lateral cortex of the body of the zygoma. So there's an instrument that has a little hook that's very thin that goes through the osteotomy. It hooks on that opening, and then their measurements, and then you determine the measurement based on that.
Amazing.
If you place an implant that's too long, and a patient has really thin skin, that can cause irritation and they can get an infection on sort of the skin area. So it's really important that we want the implant to project through, because we want it to anchor into the external cortex, but we actually don't want it to go too far, because then it could be an issue.
Well, that's the end of our questions. Once again, Dr. David, I want to thank you for an excellent presentation. For those of you who don't know, Dr. David was the first oral surgeon in first person in Canada to start doing zygomatic implants, and I think she's by far done more than anyone else, never mind in the city of Toronto, but perhaps in all of Canada. So she is a world-renowned expert. She wants to interrupt and say something. Go ahead.
No, I'm good.
Oh, okay. So, and for those of you who missed my little story at the beginning, I've watched her doing live surgery, and she's world-class. And she's not a bad person either. So once again, thank you, Dr. David, and thank you, TMFD. Thank you, Chris. Your final words?
Yes, well, thank you, Dr. Arlen. And of course, thank you, Dr. David, very much. I think this has been a very insightful presentation to help other dentists get a better understanding of how Zygoma implants can be an effective solution for patients and how to identify when they're good candidates. I think your passion for what you do is very evident and is really wonderful to see. I hope our guests come away with this greater sense of awareness and confidence around this type of procedure. And I would just like to add that as an advisor from TMFD, dentists may wish to remind their patients that the cost of these procedures may qualify for tax relief, just in case there's any hesitancy to proceed from a financial point of view. A reminder that if anyone has further questions for Dr. David, feel free to contact her by email at drdavid@implantsurgicalcare.com. So I'll say that again, drdavid@implantsurgicalcare.com, or through TMFD so that we can help. We can put her email address in the comment box as well to make it easier. So I would like to thank everyone for joining us this evening. We hope you enjoyed it. A reminder that the PACE credits will be issued within the next couple of weeks. And we hope that you'll join us again for our next presentation, What They Don't Teach You at Dental School About Selling or Buying a Dental Practice, with Bill Henderson of Henry Schein Tier 3 Brokerage Limited. Bill will provide an overview of what goes into the valuation of a dental practice, ways to build the value of a practice before selling or after buying a practice, and current trends affecting the market. This presentation is happening on Tuesday, October 17th at 7 p.m. That's Tuesday, October 17th at 7 p.m. So guests can register on the TMFD website under the Academy page. And if you've enjoyed tonight's presentation and find great value in these webinars, please get the word out there and let your colleagues know that they're welcome to join us. So as we close this evening off, I'd like to thank our speaker, Dr. Lesley David, for her valuable expertise and insight, and to Dr. Murray Arlen for his great questions and commentary. And thanks to you, our guests. It's been fun to share the evening with you. We hope you found it valuable. Thanks again, and have a good night, everyone.
Thanks a lot.
Thanks. Good night, everybody.
Good night, everyone.